think that where we left off was we did intramembranous ossification. Is that right? Okay, and we were about to do endochondral? Okay, you guys are ahead of the other class, so I don't know why. It's like 8:30 in the morning, it's hard to get me going, it's hard to get them going. We're both vaguely stupid, everybody's dumb. Okay, so here we go. Okay, so remind me, because you guys know, when we did intramembranous ossification, what kinds of bones were we making? Intramembranous makes what kind of bones? Flat bones. Give me an example. Parietal bone, sternum, ribs. Okay. And now what we are going to do is endochondral ossification. And endochondral ossification is how you make most of your other bones. But specifically, let's say we're making a long bone. Okay? Now, look all the way to the right and tell me what long bone we're making. That's the humerus. Most of you guys can recognize the humerus. If you can't, it's fine. You'll be able to recognize it next week easy because you'll do it this week. So that is the humerus. So endochondral ossification is a bit more complicated because you do the diaphysis and the epiphyses separately. Okay? So whereas intramembranous just goes from the middle out, it's basically one continuous process, right? This is going to be some overlapping processes, okay? Note to self, whenever there is a process, assume that I will ask you everything about it. Because I like processes. Don't I like processes, guys? I will make you list them out or put them in order or anything. In part because I think anatomy can be pretty damn dry. And this is a story, right? And I like stories. So I will make you tell me stories to entertain myself as I'm grading 225 tests, right? So whenever there is a process, assume you will have to know it in detail, and this is one of the first that you've learned, okay? So endochondral ossification, what we're going to do is we're going to make, let's say, a long bone. Let's say we're making a humerus, and let's talk about how this occurs. So this is a little baby fetus humerus, okay, or prehumerus, and it's made of what kind of tissue? Hyaline cartilage. And it's hyaline cartilage that is covered with perichondrium. Yeah? Okay, so it's covered with perichondrium, and then what's going to happen is the first thing is we are going to convert the perichondrium into periosteum, because we can, we've got mesenchyme, right? We've got tons of mesenchymal cells in the fetus. So we're going to convert the perichondrium into periosteum. And now that I have periosteum, I have the cells in periosteum that can make bone mass, right? Osteoblasts, osteoclasts, and osteoprogenitor cells. Got it? So now what I'm going to do is that periosteum is going to start to make my first bone mass, and it's going to make it around the diaphysis. So you're going to make a collar of bone, yeah, around the diaphysis. That's where you do your conversion first, so that's where you start working. So I'm going to have a periosteal bone collar, and it's going to be made of the easiest type of bone tissue to make, which is what? Sponge bone. Yeah, sponge bone has less mass, so it's always easier to make, right? It's got less stuff in it. So I'm going to make a spongy bone collar. I know that we're not going to leave it spongy bone, but we're going to make it spongy bone first. Okay. So in addition to making your periosteal or spongy bone collar, now what we're going to do is we're going to start working on the center of the diaphysis. And by the way, I'm teaching these as if they are discrete steps. There's a lot of overlap, but I don't know how to teach overlap at the same time, so you can look at it in the picture. So now what I'm going to do is I'm going to migrate blood vessels into the center of the diaphysis and bring with the blood vessels osteoclasts, osteoblasts, and osteoprogenitor cells. Does that make sense? And then once I have them there, I can actually start making bone mass. But what I'm going to do first is I'm going to kill off the chondrocytes that are there, but I'm going to leave the collagen fibers in there because they were already there, right? And I need collagen anyway. So kill off the chondrocytes, invade with osteoblast, osteoclast, and osteoprogenitor cells, and start laying down bone matrix, right? And of course, what kind of bone am I going to make? Yeah, no, not compact bone. What's easiest to make? You always do the easiest one first. So I'm going to make it spongy bone. I know it's not going to stay spongy bone, but it's way faster and easier to make. So now what I have is a spongy bone collar and a spongy bone middle of the diaphysis. Does that make sense? Okay, so just let that sit for a second. We'll come back and remodel it in a minute. And now, overlapping with that, now I'm going to start working on the epiphyses. And I'm going to work on those simultaneously. Oh, I forgot to mention one thing to you. The middle, right here, when you start working on the diaphysis from the middle, you call that the primary ossification center. When you were doing flat bones, you only had one ossification center, not primary, right? It was just the ossification center. Now what I'm going to do is I'm going to work on the shaft first, and then I'm going to work on the epiphyses. So I'm going to have a primary ossification center, and then I'm going to have secondary ossification centers. Does that make sense? Not secondary and tertiary, even though they're two, because they happen at the same time, right? Okay, so I have my primary ossification center, but now let's start working on the epiphyses. I'm going to start working on the epiphyses, and I'm going to do kind of the same thing. I'm going to invade that cartilage with blood vessels and bring osteoblasts, osteoclasts, and osteoprogenitor cells. Kill off the cartilage cells, start making bone matrix. So those two at the ends, these are secondary ossification centers. Yes? Okay. So I've been working on the shaft. I'm not done with it yet. So now let's go back and remodel the shaft as the epiphyses are happening. So now, the way I want the shaft to be by the time the baby is born is I need a medullary cavity, and then primarily what kind of bone around the shaft? Compact bone, exactly. So you guys tell me, in order to remodel from a kind of solid, spongy bone shaft into what you guys just said, what kinds of cells should be most active in the center? Osteoclasts, exactly. So you're going to whittle out the center, right? Okay. Where's the marrow going to come from? Mesenchyme. You can make marrow, right? Okay. And then what kinds of cells should be most active around the outside of the shaft? Osteoblasts. Now the net is, of course, more osteoblast activity than osteoclasts, right? But you've got to whittle out the middle, right? And then you've got to end up with an increase in bone mass, but more around the outside than around the inside, right? So that remodeling process is going to happen, and now I have basically what the shaft should look like, right? Okay. And then what about the epiphyses? The epiphyses, you just do the same thing, right? You basically just need to remodel it so that you have spongy bone in the middle and compact bone around the outside, right? And you do that with osteoblasts, osteoclasts, and osteoprogenitor cells, right? So it's pretty much the same story. You always start with spongy bone, and then you remodel later, right? Okay, so by the time you're about 5 years old, so this is, of course, embryonically, right? And then remember that you're probably between here and here when you're born, because remember that you don't have, actually maybe you're even about between here and here when you're born. You really haven't ossified your epiphyses almost at all yet when you're born. So then you're born, so this is maybe birthish to 5 years. This is about 5 years, not proportionally, just like the level of development and bone remodeling. So now I want to talk about what happens from that point until you actually finish growing in length. How does that process happen? So we did our epiphyses. So let's say this is going to be by about year 5 until you are about to hit puberty. So my little boy is 11 and a half. He's like pre-puberty. He's like got a zip the other day and was completely like thrown by it. He's like, "Is this my future?" I'm like, "Yeah, totally." But also girls, so it'll be fine. From 5 until you start to hit puberty is basically going to be this bone right here to varying degrees. So let's talk about how you are going to grow in length. Bone growth in length from here to here, not proportionally. Bone growth in length is called interstitial growth, okay? And it's really kind of cool the way that it works. Interstitial growth is going to go pretty much from this age until your epiphyseal plates close, your growth plates close, which in females is usually around 18 to 19, and in males is usually around 21 to 22, but that's totally an average, because we know people who start growing at 14. And then my best friend's husband was 5'7" when he got into college, and when he graduated, he was 6'3". So that was an unusual time to grow up, but it does happen. So this is just an average. So let's see what happens. What is actually going to happen is by the time you're here at 5, you only have cartilage left behind in a couple of places. You have cartilage at both ends. That's called articular cartilage. Yeah? It was there from the beginning. You just never ossified it, right? So what kind of tissue is it? hyaline cartilage still, right? And then what you have here is you have a plate of cartilage that never ossified, right? And that's called the epiphyseal plate, or people refer to it as a growth plate. Okay, so we're going to talk about how the growth plate actually works. So here is a histology slide showing you a growth plate, right? So here is bone tissue, and here is cartilage tissue. So I want to talk about how bone growth and length works from like 5 to 18, 19, 22, whenever. So how does it work? What works is, what happens is, so I want you to imagine you've got 2 epiphyseal plates. Say this is a femur with epiphyseal plates of a 5-year-old. What's going to happen is they're going to end up doing this as he ages, right? Okay? Now, of course, it's going to get bigger as well in width, but we'll talk about that in just a second. So how does an epiphyseal plate work? What happens is you are doing 2 things at each epiphyseal plate. You're doing cartilage cell division and growth, and then you're doing ossification. Cartilage cell division and growth and ossification. Cartilage cell division and growth and ossification. Does that make sense? You're doing the same thing at that side, okay? So what's going to happen is your growth plates are going to be moving away from one another, but until you hit puberty, or about to hit puberty, cartilage growth and ossification happen at the same rate. So what happens to the thickness of the growth plate in a child age 5 to 11? If cartilage growth and ossification are happening at the same rate, what happens to the thickness? Stays the same, exactly, right? So you've got a thick growth plate that's just moving away, right? That makes sense? And then once you hit puberty, your sex hormones jack up everything for the rest of your life, including your bone growth. And so your sex hormones, whether it be androgens like testosterone or estrogens, and they do it at slightly different rates and at slightly different times. You know, girls usually hit puberty slightly before boys, but boys grow for longer. Okay, so what's going to happen is as soon as your sex hormones get involved, what they will do is they will increase both of them. They will increase cartilage growth and ossification, but not at the same rate. So you're going to hit a growth spurt, but what's going to happen is they increase ossification more than cartilage growth. And what happens to the thickness of your growth plates after you hit puberty? Thin, 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 seal. Does that make sense? Okay. And it's because of your surge of sex hormones. Yeah? Okay. So the sex hormones will actually seal your growth plates eventually, and that will matter. So I'll come back to that in just a second. So let's talk about what else is needed. So bone lengthens an average of 2 to 3 inches per year, but we know that that's an average too, because there are years in which you don't grow very much and there are years in which you grow a ton, right? And it's 2 to 3 inches per year on average, but obviously I didn't grow anywhere near as much as he did, and he's young enough to be my child, right? So, and he's tall, so it's not the same, right? It's just an average of 2 to 3 inches per year. So stops 18-ish in females, 21, 22-ish in males, but it requires a bunch of things, and if you are missing any of these things, it's going to impact your bone growth, okay? So this is important for parents to know. It's also important for people who are still growing. So you need adequate levels of hormones that are involved in cell division and growth. You need adequate levels of growth hormone and thyroid hormone. If you don't have them, it will impact your bone growth. You can, for instance, have something called pituitary dwarfism when you have inadequate amounts of growth hormone. Good. You can't do a damn thing about that except get diagnosed and treated for it. The other ones you can. You need adequate levels of nutrition. You need adequate calcium for your bone mass. You need adequate protein for your bone mass. And this one's a big one here in Utah. You need adequate levels of vitamin D for calcium absorption. I mentioned it, but it's worth mentioning again because we are in the middle of winter, despite the appearances of no damn snow. Utah, in the winter, people are generally vitamin D deficient because of our inversion. And vitamin D will cause problems with calcium absorption. Most of us are vitamin D deficient, especially if you have inherently dark skin. Because how do you make vitamin D? UV radiation getting to the deeper layers of your skin. If you are a person who lives in Salt Lake City in the winter and you are of African descent, I can almost guarantee that you're going to be vitamin D deficient. Does that make sense? So there are things you can do about it. You can get more sunlight. You can supplement your vitamin D in the winter. Okay, you also need these two. These two are necessary for cell division of all sorts, including bone cell division, okay? Sex hormones will speed the process up. The sex hormone surge will eventually seal your epiphyseal plates, and sometimes you can use that clinically, and sometimes people accidentally seal their epiphyseal plates. You do not want a 17-year-old boy to decide he wants to be super buff and start using testosterone. He's going to get super buff, yeah, if he works out, and he's also going to be shorter than he otherwise would be. Yes? Because it will seal your epiphyseal plates. He's also probably going to be a jerk and have a bunch of zits, and nobody's going to want to hang out with him, and he'll smell weird too. Or my husband's family, so sometimes they clinically use sex hormones to seal growth plates on purpose. My husband is Dutch. They're the tallest people on the planet. My husband is 6'6", his dad is 6'8". He's got 3 sisters, 5'11", 6 foot, and 6'1", but the 2 tallest ones only stopped growing because they artificially sealed their growth plates on purpose because they were 12 and 13, and they were predicted to be 6'4" and 6'3", which might sound great as an adult. It's horrible as an adolescent. They are both freaking knockouts right now, but they were grasshoppers, you know, when they were. So what they decided to do is, consulting with their physician and their parents, they decided to seal their growth plates by starting to take high-dose estrogen birth control until their epiphyseal plates sealed. And now they are 6 foot and 6'1". So it's a decision people can make, and they made it. So you can use it to seal them and become an epiphyseal line. So this is what it looks like when the plate is open from the outside. This is what it looks like when from the inside. This is what it looks like when the plate is open from the outside in the process of sealing. When it completely seals, you won't see much except a little remnant of a little suture there. Okay, so now your bones don't just grow longer, they also grow wider, right? So interstitial growth is growing this way, appositional growth is growing this way. So if you look at a little teeny baby femur, it's going to be really small in cross-section, but an adult one is not. And this process is called appositional growth. It's pretty easy to understand because basically you have a net gain in bone mass, right, because you get more bone, right? But which cell is more active on the outside and which cell is more active on the inside? Outside? Osteoblast. Inside? Osteoclast, right? And that's an oversimplification, but it's pretty much how it works, right? More osteoblast activity on the outside and more osteoclast activity on the inside. Good? Okay. Now, most of us are over age 22. Not all of us. So most of us are finished growing in height. I really would have liked another year of growing in height because then I could eat more and it would be amazing. Right? That's the only reason I really want to be tall. It's because I like food way more than my husband, who's 6'6", and he can eat like 7 times what I can. And if he gains weight, it's like goes into a toe, and like nobody notices, right? And like my mother-in-law is like, "Oh, do we need an intervention? Because I think you've gained 5 pounds." The Dutch, I don't know if you guys, is anybody Dutch? The Dutch say every single thing that they think. It's amazing to have that as a mother-in-law, I gotta tell you. She's like, I don't even know when the last time was that you did your baseboards. And I was like, I didn't even know people did their baseboards. You wanna do them? In an adult, what happens? What happens is from the time you stop growing until the time you start shrinking, which usually you get a couple of good decades pretty much. From the time you stop growing until you hit your late 30s, early 40s, usually your bone mass stays relatively constant, but it's not inactive because generally what's happening is every time you take in abundant levels of calcium, you make deposits, and every time you don't take in enough, you make withdrawals. But the net effect is that you hardly notice any change in bone mass at all. Does that make sense? So basically you're resorbing and depositing at about the same rate. So the process is usually balanced and there's no obvious change, but then it does start to change. Okay, so as you get to be an adult, what do you need in order to maintain your bone mass? In order to maintain your bone mass, you need a lot of the same things that you needed as a child. You need growth hormone and thyroid hormone. You need a hormone called cortisol, which is necessary it's a metabolic supporting hormone. All of those have to be normal, meaning that if any of those are bad, you're going to probably see impacts on your bone mass. And then, of course, you need your sex hormones. one of the interesting things is as soon as you start using your sex hormones to build your bone mass, you don't ever get to stop or else you lose your bone mass. Okay? So if, for instance, a male stopped producing testosterone, he would start losing his bone mass. When a woman hits menopause, she starts losing her bone mass. We'll talk about that in just a second. Okay, and then you need some calcium regulating hormones. And your calcium regulating hormones, a little bit of fizz that I want to teach you guys. Okay, there are two hormones that are really primarily related to your blood calcium levels. And what they're doing is they're regulating when you make deposits and withdrawals into your skeletal system then. Does that make sense to you? Okay, so remember that calcium is about more than just your skeleton. It's about blood clotting, it's about cardiac muscle contraction, it's about nervous system transmission. So arguably, if you needed calcium, make a withdrawal because that's more important than your bone mass. So what we will want and what we're actually regulating is the concentration of calcium, but not really the concentration of calcium in our bone. We're regulating the concentration of calcium in our blood, okay? And let's say this is the ideal range for calcium in our bloodstream. You with me? Okay, so what is going to happen with this is that we use two hormones as triggers for deposits and withdrawals into our bone. You with me? Okay, so here's the deal. There are two hormones. There is parathyroid hormone and calcitonin. Here's what happens. Let's say I'm fasting and I have not eaten enough calcium. Then what I'm going to need to do is I'm going to need to make a withdrawal, right, from my bone mass and dump it into my bloodstream. Okay? So the hormone that does that, so my calcium is at the low end of the acceptable range and I need it to go up. The hormone that triggers that is called PTH, parathyroid hormone from the parathyroid gland. Now, what cell do you think it targets? Osteoblasts or osteoclasts? And what does it do? Increase or decrease the activity of osteoclasts? Increases the activity of osteoclasts, right? Gobble up the bone matrix, but where do they put it? Into the bloodstream. Does that make sense? Okay?
So it decreases.
No, I didn't say decrease. Increase osteoclast activity. Good? Increase osteoclast activity. And then, of course, your blood calcium goes up, yeah? And as soon as it gets to acceptable levels, you just stop secreting it, stop increasing osteoclast activity. What about when you eat plenty of calcium? So you eat a meal that's got broccoli, it's cheese, you know, a milkshake for dessert, right? Then you need to make a deposit. But there is another hormone that tells you when you should make a deposit. And that hormone is called calcitonin. And calcitonin, counterintuitively, does not trigger osteoblast activity. It actually just decreases osteoclast activity. Wouldn't that accomplish the same thing with less materials? If your osteoblast and osteoclast activity are balanced, then you have no net change. But what if you just put your foot on osteoclast activity? Then you're going to end up making a net deposit into your bone mass. Does that make sense? Okay. Yeah? Okay. So I always remember calcitonin, what it does, because it tones down blood calcium. Do you see that? Okay? Not bone, but blood calcium. Okay? And then you just continue to do this over time. Yeah? So you regulate your blood calcium so that it stays within a relatively healthy range. But let's think about a situation in which it can't really stay in a healthy range without making long-term withdrawals, like a person with anorexia. So we've got a person with anorexia. Which of these hormones is really going to be secreted very frequently? PTH. Over and over and over and over and over again. What can you predict about the bone mass of someone with anorexia over time? They're going to lose tons and tons of bone mass. Why? Because you need that calcium for more important things than your bone mass, and you're not actually giving it to yourself, right? So you can have a person who is in her 20s with the bones of a 70-year-old, breaking hips and things like that. Of course, it happens to males too, but we'll see that males actually start out with more bone mass than females to begin with. Okay, so so this is just a teeny little bit of physiology. You will see an abundance of these kinds of things in phys. It's just like example after example after example of regulating these levels. Okay, what else do you need as an adult to maintain your bone mass? You need some vitamins, kind of the same ones that you needed before. vitamin A, C, D, proteins, calcium, vitamin D. And then you need to have the use it or lose it knowledge about bone mass. You guys know use it or lose it with muscles, right? So you work out. You're like, hey, my pecs look amazing. And then you don't work out for 6 weeks and you're like, I am a 12-year-old boy, right? Same thing over and over again. But the same thing is happening with your bones, okay? Their bones are use it or lose it. Here's what happens with your bones when you stress them, not emotional stress, but mechanical stress and gravity, you're communicating with them. So when you walk, you're actually pulling on your bones and you're making them resist gravity. Now let's talk about, okay, so let's say you are going to start working out and you're going to start doing bicep curls, right? When you start doing bicep curls, what you are doing is you are stressing the entire bone, right, and these as well, but you're stressing really dramatically at the points of insertion of the muscles. With me? So when you stress them at those points, what you do is you actually bend the bone just a little bit, and what that does is open some ion channels. For those of you who have had phys, they're voltage-gated ion channels. You open those ion channels, and what that does is inhibits osteoclast activity at that site and increases osteoblast activity at that site. So what do you get at that site? You get more bone mass built at that site. Why? Because you're communicating to your skeleton that I'm going to try to lift this damn thing over and over again. And it's like, oh, okay, I got you, bro. Right? And it's like building more, right? Bone mass. Does that make sense? So also, let's say instead of that, you decide you're going to sit on the damn couch for the rest of your life. You're going to start losing bone mass because you really don't need it, right? You're communicating to your skeleton that you're not going to do a damn thing for the foreseeable future. And it's like, you don't need that much bone mass. So the mechanical stress, bone really responds to mechanical stress by remodeling to become thicker and heavier. And that means that the other situation is true. If you have someone who's bedridden, they will be losing bone mass, right? Is it completely irreversible? No, it depends on how long they're bedridden. What about if you cast? Has anybody ever casted the wrist? Right? There's hardly anything there except bone. You can see how much bone mass you lose, but you can get it back, right? You can start, it's because you're not using it. That's why you lose it. And then a really interesting one is in zero gravity, when you have astronauts, initially it was cosmonauts. So the very first long-term space flights were not US led, they were USSR led, okay? Long-term space flights. And they predicted, of course, that you were going to lose bone and muscle mass, because it's not like the scientists are dumb. But they did not predict that you were going to lose so much, but that when the cosmonauts came back, they couldn't walk. They had lost so much bone and muscle mass that they couldn't walk. So now what they do is when astronauts go up onto the International Space Station, you can use that knowledge to, instead of, if you can't have mechanical stress because of the lack of gravity, they set up pulley systems, but then they also use something like a TENS unit in which they, right? Because it opens those ion channels, right? So you can use that to maintain the bone mass. And then there was this really cool, I don't know if you guys, do you know the Kelly astronauts? There's twin astronauts, right? You should know this because this is amazing. Okay, first of all, astronauts are amazing, okay? Because they're smarter than you, they're more athletic than you, and they're braver than you. So they're like the real superheroes. So these parents raised identical twin astronauts. That's some parenting high five, that's all I have to say. Okay, so Scott Kelly is one of the astronauts, and his brother, what's his other brother's name, does anybody know? Can't remember. So they wanted to know the impact of long-term spaceflight on human physiology. They have a perfect setup right here. They sent one of them up into space for a year. The other one stayed here. They did exactly the same exercise regimen, ate exactly the same food for a year, right? And then brought them back. And now they're doing a longitudinal study to see what lack of gravity in long-term space. That's a beautifully designed study right there. If only we had more twin astronauts, right? I really want to high-five their parents, honestly. I'm like, I don't know what you did, but okay. So now, of course, we can also take advantage of the fact that we know that electrical stimulation can increase osteoblast activity and decrease osteoclast activity. If you have a crushing fracture that can't be casted or isn't healing well, they can actually zap it to help heal right? It's kind of like a TENS unit, but it's at a different frequency to actually stimulate that. Okay, so now let's talk about repair of fractures, and then we'll start talking about losing your bone mass. Okay, so when you fracture something, how does it repair? It's pretty easy, actually, because you already know ossification. So it's a little mini ossification process. So let's talk about it. So this is like a long bone fracture. It looks like I have no idea which bone, but in the medullary cavity. So how do you heal with a fracture? Well, first of all, healing in bones in a healthy person is pretty guaranteed because they're super duper vascular, as long as you have adequate nutrients and all that kind of stuff. So first thing that you have to do is when you break a bone, you have to make sure you don't bleed out. So you have to form a clot or a hematoma. Luckily, in a healthy person, bones clot relatively readily because calcium is one of the triggers for clotting. You have boatloads of calcium there, so they usually clot pretty regularly. And then what we do is after this takes, to get to this point, 3-4 weeks. Then we basically make cartilage first. It's easier to make. Only we make really strong cartilage to seal the two ends together. So instead of just doing hyaline cartilage, which is what was there first, hyaline cartilage plus extra collagen is fibrocartilage, right? Okay, so, but this is super bendy, right? It's going to bend at that point. So if this was a castable bone, and not all bones are castable, you would be casted here, right? Okay, so now what I'm going to do is, this takes up to 6 weeks right here. Now I'm going to start a little mini ossification procedure, and I'm going to invade with osteoblast, osteoclast, and osteoprogenitor cells. And I'm going to start to make the easiest bone tissue first, which is what? Spongy bone tissue first. Even if that's not what I want there, that's what I'm going to make there first. And I'm going to make a spongy bone sort of callus between the two of them. It's usually pretty lumpy. This is about 6 weeks in, depending on whether you can cast it or not. And then, what do they usually do if you are casted? What do they usually do at around 6 weeks? They take it off. But if I broke this snowboarding and I go snowboarding again at that point, what's going to happen? You're going to break it right there at the same point. So why do they take it off at all? Yes, you need to stress it to increase your osteoblast activity and decrease your osteoclast activity, but you need to stress it gently, right? So what often happens, especially with adolescent boys, break it snowboarding, take it off. What do? Go snowboarding. I love just, men are great. The combination of testosterone with a not yet formed prefrontal cortex makes you really, really predisposed to risk-taking behaviors. And so the prefrontal cortex is what lets you understand the long-term implications of your decisions. And if you combine lots of testosterone with that not very well developed, you get a lot of risk-taking behaviors, which I'm trying to parent through. I have an 11-year-old and an 18-year-old boy. And then I've got a girl who's just like, I'm just going to sit around and take pictures of myself all damn day. What the hell? How did she decide that that was a hobby? Really, honestly, I think she takes about 150 pictures of herself a day. I'm like, that is probably not healthy. Anyway, so what happens is if you stress it before remodeling occurs, you're going to break it right at the same point. But if you let remodeling occur, which takes months, then what's going to happen is you're going to end up with more bone tissue at the site of the break. Yeah? So you'll always be able to see that it broke there because you'll have the remnants in the tissue that looks like an epiphyseal line. It'll like always be able to see. It's not going to be very, very weak here, but if you do the same thing, you might break it right next to it, right? Because it's like you've got one really strong link in a chain and the ones next to it a little weaker. Does that make sense? Okay. So you can always see it on an x-ray, which brings us to when a family brings a child into an emergency room, they can, and there's bone break, and they look at it, and there's not one bone break, but there's 8. What do you usually conclude? Yeah, some kind of trauma, potentially child abuse. Now, are there disorders that cause bones to break really readily? There are, but they are not as common as child abuse. okay? So you can always see the sites of bone breaks. We can use it. I used to work with forensics when I was in graduate school. We can use x-rays to identify people, right? Because the sites of bone break are really, really dependable and you can always see them. So this is how you heal a fracture. Now, if you can't cast it, then it usually heals a little more slowly, right? So has anybody ever broken their coccyx? Yeah, what did they tell you?
You just have to sit on the donut.
For however long, right? Okay. How about breaking a toe? You're like, it's broken. There, you got a broken toe. Go along your way, right? So you can't cast everything, right? So, so if you can't cast it, sometimes it takes a little longer for the healing process to go on. Okay, so let's talk about the other end of life. We did growth, and now let's start talking about when you start losing your bone mass. When you start losing your bone mass, which we all will, the natural loss of bone mass that is associated with aging is called osteopenia. All of us will get osteopenia. When it starts to have symptoms and compromise normal function, it's called osteoporosis. Yeah? Not all of us will get osteoporosis. Okay? So all of us will start to lose bone mass. So what are some symptoms of osteoporosis? I'll show you guys a couple of pictures. So you saw this one last time, right? So this is normal spongy bone and osteoporotic spongy bone, and here it is a little closer. Normal spongy bone, osteoporotic spongy bone. You can see that you actually lose structural stability with osteoporotic spongy bone. So what are some symptoms that occur as a person gets osteoporosis? You have very fragile, easily fractured bones. So why can an 80-year-old and a 20-year-old have exactly the same fall and an 80-year-old break a hip? It's because the internal structural stability of the os coxa is compromised by loss of bone mass, right? So fragile, easily fractured bones. One of the other things is lost height. Anybody have any idea why you tend to lose height as you age? It's related to this. Go ahead. Yes, exactly. Remember the bodies of your vertebrae, right? And they are mostly, they're just comet bone at the edges and really spongy bone in the middle. And as you age and start to lose your bone mass, you tend to compress those, okay? So you lose height. In addition, of course, there's stuff going on with the disc, but we're not talking about the cartilage right now. In addition, of course, your musculature often gets weaker, so you tend to hunch, so that, of course, adds to the effect of losing height. So lost height, lost teeth. Teeth is an interesting one. You can lose teeth with osteoporosis, not because there's anything wrong with your teeth, but because, what are those little pockets that hold onto your teeth? Alveoli. Alveoli in a young person is really deep. As you age and lose bone mass, your alveolus gets shallow, right? The mandible of a person in their 80s is about a third smaller than a person in their 30s, right? And so you can lose perfectly healthy teeth associated with osteoporosis. So osteoporosis. Now, how do you initially determine that you're losing bone mass? They can do bone scans, and a certain type of bone scan will show up when you're actually losing your bone mass. So let's talk about who is most affected by loss of bone mass. Who is more likely to be affected by osteopenia and therefore osteoporosis. So let's talk about that. So everyone loses bone mass as they age, right? But the sexes are not equal in their loss of bone mass. Bone mass loss begins about the age that you stop being wiggly, which is in your 30s and 40s. Okay? You don't have to stop being wiggly, but don't we? Yes, we do, right? You're like, I had a job where I walked around all the time, I waited tables, went to college, got the job I want, sat on my butt for a long time, right? You don't have to do that, but you're going to start losing bone mass and muscle mass, and you're also going to start gaining weight when that occurs. So, and guess who is the most likely profession to lose bone mass and gain weight? Nurses.
Why?
Because you sit on your butt too much. Yeah, be a wiggly nurse. There are wiggly nurses. You can be one of them. So get up and do stuff, right? So yeah, nurses also tend to have more varicose veins than other professions. They gain a lot of weight, but you don't have to be one. There are hot nurses. You see them, right? You're like looking at them, you're like, dude. Okay, so now, women lose far more bone mass than men, and they started with less. Because of the difference in body size, on average, women tend to have around 30% less bone mass than men. Because of body size and the fact that testosterone actually causes a little bit more bone mass development than estrogen does, okay? So you started out with less, and then after you hit your 30s, on average, women lose around 8% per decade, most of that after menopause. So that's an average, but most of it is after menopause. And men only lose about 3% of it per decade. So they have more and they lose it more slowly. And why is that? Women lose most of their estrogen during menopause, and menopause happens, once it starts, it happens relatively quickly. It can start anywhere between your mid-40s and your mid-60s, really. But when it starts, you lose your estrogens, and you usually lose them over the course of 1 or 2 years. And then you start losing your bone mass because you needed estrogen to support your bone mass. What about men? Do men have the equivalent of a menopause? Not really. They do start to taper off in their testosterone, and their sex drive will taper off, and they're less likely to be aggressive. Testosterone's assertion and aggression as well. Their sex drive will taper off, but it tapers off so gradually that you can have 85-year-old men that can still father children, as long as they can find a 25-year-old woman to sleep with them, which seems to be correlated to the size of their bank account for some reason. I don't know why. So it tapers off pretty gradually. In males, they keep a lot of their testosterone as they age. So what else is a good predictor? Your ancestry. So let's talk a little bit about ancestry. Biologically, the term race is not a thing. Socially, I totally acknowledge that it is. But biologically, you can just look at your ancestry and you can say that there are these big blobs of ancestry. Of course, we're all mutts now anyway, right? But what can you predict about your ancestry and your likelihood of osteoporosis? Some ancestral groups, people of African descent, tend to have very dense bones. So they're less likely to be impacted by osteopenia and osteoporosis. Caucasian people of European, including Western and parts of Eastern European, tend to have less dense bone mass, so they're more likely. And the people who are most likely to have osteopenia and osteoporosis are people of a big swath of Asia, including Native Americans, like me, because we're Asians. We moved over. All of the evidence says that most Native Americans came over from Asia really early. So people of Asian descent are most likely of the population group to have osteoporosis. But then there's something else that adds to that. What else adds to that is that little women, teeny women, and of course a lot of Asian women are smaller than Caucasian women. Not all of them, but a lot of them. Little women have less bone mass to start with than big women. In addition, if you're a big woman, I don't care if you're a big fat woman or if you're a big muscular woman, hauling your big old self around is weight-bearing activity, isn't it? Right? So if you're tiny, you have less bone mass to start with, and it's not as much strain on your bones to haul yourself around. Okay? In addition, there's one other thing. Fat tissue is where you make estrogen. So if you're very thin, very tiny, then as you start losing your estrogen, you could actually make estrogen from your fat tissue. Estrogen is made from fat tissue no matter when. But if you are aging, losing bone mass, and very thin, then you don't really have anything to make it from. So as you age, as you get into your 40s, it's actually a little better for you to have a little bit of meat on your bones, a little bit of fat. So you make estrogen from your fat tissue after menopause. And then the extremes are also true. Now, I'm not saying you need to be obese, right? That's not what I'm saying. I'm saying a little bit of fat tissue is a good source. Now, what about the other extreme? Extremely thin women, okay, will stop producing estrogen altogether. Now, it could be because you were an elite athlete, like a gymnast, You guys know that gymnasts have to be extremely careful about how much body fat they have, and they are not joking around with how much body fat. So you can have someone who starts elite competitive level gymnastics at like age 6 and does it until she's 20, and she might never menstruate the entire time because her body fat percentage is so low. Am I saying that she's in bad shape? No. But she might never menstruate. And what can you tell me about her height if she ever actually never, right? If you never let yourself make normal levels of estrogen, it's going to limit your height, right? And of course, it's going to limit your reproductive capacity. And sometimes that's permanent, sometimes it's not, okay? So, and then anorexia, again, just one more time talking about anorexia. If you have a person who's dealing with anorexia, and it's more often to be women than men, they can have the bones of a 70-year-old at the age of 20. The first semester that I taught, I had a student who was 26, and I was only 30 when I started teaching my first faculty job. After the class was over, we became friends, and then I got to learn a little bit about her family history. She had a brother and a sister, and her mom was still in the picture, and the entire family had been treated for anorexia. And her mom was in her 50s, had already broken a hip, and was in a walker. Okay, her sister had already broken bones and was being treated for osteoporosis, and she was being treated for osteoporosis in her 20s because of this massive predisposition to sort of eating disorders. And the question, of course, came up to me: nature, nurture, both in that situation? I don't know. But so you lose massive amounts of bone mass when you do not get adequate nutrients. Okay, so what can you do? What can you do to prevent it? Well, you know already what you can do. If it's use it or lose it, then use it. Go ahead. Oh, okay. If it's use it or lose it, then use it. Okay? You need to use your skeletal system to maintain your skeletal systems. Walking is fine for your spine and your hips. You don't even need to run. Running is hard on your joints. It's really good for your cardiovascular, respiratory, and muscular system, but sometimes it's hard on your joints. You can walk for your spine and hips. You can do weightlifting, push-ups for your upper body. I know that a lot of times women are really averse to doing any weightlifting because they think they're accidentally going to get really buff. Nobody accidentally gets buff. It doesn't happen on accident, especially after age 17, right? Like, look back at 17, you're like, I was so hot and I didn't appreciate it. And like at age 40, you're like, I'm just trying to hold it together. It's like all the stuff is going to the wrong place. So now swimming is a phenomenal exercise, but it is not particularly good for maintaining your bone mass. Why? What? Bones get soft because really what's taking most of the stress is the water, right? You're not actually gravity stressing. So do you think that Michael Phelps actually became as strong as he is just by swimming? No. He, of course, was going to do a lot of weightlifting as well, right? A lot of other kinds of exercise to maintain his bone mass. What else should you do? Nutrition, calcium, vitamin C, D, and protein. Pay special attention to vitamin D if you're in Utah in the winter and your skin is dark. Stop smoking. Smoking zaps vitamin C from your system, which makes it hard to maintain a lot of your growing tissues, including your bone mass. So you do lose bone mass as you smoke. If you are postmenopausal, then you can consider hormone replacement therapy, but put an asterisk on that, because if you have a family history of breast or ovarian cancer, hormone replacement therapy can increase your risk of breast or ovarian cancer. So that's a conversation to have with a doctor and knowing a little bit about your history. And then what else can you do? Fluoride, calcitonin, our friend right here, right? And then there are some medications like Fosamax and some others that actually can stop bone mass loss and even replace it. But historically speaking, the most effective ones have been really, really expensive. When Fosamax came out about 10 years ago, it was about $800 a month for 3 pills. Now it's cheaper, but the newer one that's still patented that works even better is still cost prohibitive for anyone who has not got an amazing insurance policy and or independently wealthy. So, of course, you are more likely to get better health care when you have money, because we're in the United States. Last thing in this set of notes will bring us directly into the next one. So let me tell you guys something before I move on. You are going to have a quiz on Thursday, yeah? and the quiz is going to be over bones. What's it going to cover? This entire set of notes, because we will finish this in just a minute, okay? And the bones from lab. Okay. Specifically, I know that you have all done axial skeleton deeply. So I can test a little more deeply on axial skeleton. But I can also expect that you would be able to recognize a picture of the femur. Yeah? Even if you haven't done it by Thursday, you can look ahead, can't you? Okay. So I am going to test over this set of notes, or quiz over this set of notes, axial skeleton including features. Appendicular I'll go easy on. Everybody good? Okay. And then your test is Tuesday, yeah? A week from today. And what I will do is, and listen to this, you are going to have a take-home quiz, a top hat quiz, that I am going to put up Thursday afternoon, and you will have, you will have from Thursday until before classes start on Tuesday to do it. I'm going to make it do like midnight, because you need to do it before then, right? To do it, it'll be take home, it'll be open notes. There's no reason on earth that you shouldn't get 100 on it. Why the hell am I doing it? Because I'm going to make you rifle through your notes to find stuff so that you're really familiar with them. I'll give you a good idea of what kinds of questions will be asked on the test, and you're going to have some time to sit with it, right? So you'll basically have 4 or 5 days to work with that take home. So basically I'm telling you that you got 3 things in the near future. You have a quiz on Thursday in class. You're going to have a take home quiz from Thursday to Monday. Yeah? You'll have the whole damn time to do it. Use any resources you want. You should get 100 on it. Okay? And then that should get you ready, I hope, for Tuesday, which is your test, right? I want you to do well on your first test. It's the easiest test of the entire semester, and I want you to keep that grade high because it doesn't get any easier after that. Does that make sense? Okay, all right, so let us briefly start. Chapter 9 is about articulations. Now, this test will not include all of chapter 9 because chapter 9 is like how the bones come together, which is articulations. But then it also leads into body movements, which is how the muscles move the joints. So what do you study out of chapter 9? Exactly what's on your notes. That's what you study. Always, 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 for me, use your notes as your study guide, right? Don't go finding something in the textbook that I didn't talk about in the notes. It may very well be important, but I had to choose, right? I had to choose what I was going to cover. Okay, so articulations is chapter 9. So what we're going to do is start talking about those. Articulations are joints. It's just a fancy word for joints. And so first let's talk about the kinds of articulations that exist. Articulations is where two bones come together, but not all of them are wiggly. I know that we think of these as joints, but the sutures in your cranium are also joints, aren't they? It's where 2 bones come together. And these are not supposed to be wiggly, and these are really supposed to be wiggly, right? So there's several different categories of articulations. So here we go. As far as articulations, and I'll show you pictures in just a second. There are wiggly ones, and there are not wiggly ones. There are stable ones, and there are not stable ones. Not surprisingly, the most stable, right, are the least movable, yeah? So a fibrous joint like a suture is very, very stable, but it's not wiggly. The other extreme is the wiggliest ones, yeah, are also the least stable. What is the joint in your body that is most likely to be disarticulated? Shoulders. Shoulders are most likely to be disarticulated. And that is because they have more range of motion than any other joint in the body, and you sacrifice stability for mobility. The second most likely one to be dislocated is the hip. Have you ever heard of anybody dislocating a cranial suture? I haven't. Maybe it's happened because everything that could possibly go wrong has gone wrong with the human body, but I've never heard of it. Okay? So what we have is 3 different categories of joints. Let's talk about them. So with classification of joints, the first one is called a fibrous joint. And a fibrous joint has bone, just like ligaments or tendons between them, and then other bone. Does that make sense? Okay? So a suture is one of those. Bone, just some teeny tiny little ligaments holding it together, and then other bone. Okay? And the sutures are really stable because they do this as well, right? They're serrated. So if somebody smacked me on the back of the head, it would slide through and slice my brain open. Okay? So that's a suture. What holds onto your teeth is another fibrous joint, because you've got periodontal ligaments that are just holding them in there. And they shouldn't wiggle, right? In an adult, they shouldn't wiggle. And then this one's the most wiggly of the least wiggly category. This is called a syndesmosis. Here's what it is. The radius and the ulna have a big sheet between them called the interosseous membrane. It's called an aponeurosis. It's a big sheet of tendon. And what it's really trying to do is to make sure that they stay the same distance apart from one another, despite the fact that you pronate and supinate. Does that make sense? So although it's wigglier than the other two, it's still not very wiggly, right? It's still holding them, right? Okay, so that's called, these are all fibrous joints, okay? This interosseous membrane will be a site of attachment for some of the muscles that you're gonna learn too. Okay, and then the next wiggly ones are the ones that go not bone, ligament, bone, but bone, cartilage, bone. With me? Okay. So here's classic. These are called cartilaginous joints, and these are classic cartilaginous joints right here between your ribs and your sternum. You can see that they got some wiggle to them, right? Definitely more than this, but less than this. This is called a cartilaginous joint, and you have two different categories of cartilaginous joint. If it goes bone, hyaline cartilage bone, it's called a synchondrosis. Okay? If it goes bone, fibrocartilage bone, it's called a symphysis. And you've already met one, haven't you? A pubic symphysis, yeah? Bone, fibrocartilage bone. It's got a little wiggle to it. It's especially important during childbirth if that thing has a little give to it. And then these are all symphyses as well. That makes sense? Bone, fibrocartilage bone. So they're more wiggly than the fibrous ones, but they're not as wiggly as the one that we're about to talk about. And the one that we're about to talk about is the wiggliest one. And how are these formed? So listen, this is how this one goes. Okay, these are super wiggly, which means there's a likelihood of friction in there, right? So here's what it goes. Bone, cartilage, fluid, cartilage, bone. Fluid in between the two of them. Because what happens if I rub cartilage against cartilage? You start to break it down. And how well does cartilage heal? It doesn't really, right? Does that make sense? So with these, if I've got them wiggly, I'm going to have fluid between them. Does that make sense? So this is called a synovial joint. The fluid that's inside of it is called a synovial fluid. And it's kind of like motor oil. It's really viscous, okay? So before we get into it in detail, somebody tell me what this is. That's an epiphyseal line when it seals, right? Okay, so this is an adult joint. I have no idea which joint they're trying to show me, but it's an adult joint, okay? So what we are going to see with this adult joint, synovial joint, is it's going to be wiggly. There's going to be fluid in between here. So what I'm going to have is bone, and this is the articular cartilage. FYI, articular cartilage in synovial joints doesn't have any perichondrium around it, because it doesn't really need it, because the fluid right here is really rich in nutrients, and it just gives nutrients to the cartilage. So this is articular cartilage. This is going to be filled with fluid called synovial fluid. The fluid is made by this membrane called the synovial membrane that's in purple right there. It's a weird tissue that you didn't learn. It looks like an epithelial tissue, but it has secretory capacity, and it's a weird looking tissue. It's called the synovial membrane. Now, how do you hold these two bones together? So this would be like a finger or like my knee. So how the two bones are held together, but actually sort of apart by a joint capsule. And I want you to imagine with the joint capsule that you take one of those soccer socks that are really long and you pull them over your knee, right? So you've got it here, around the knee, and then here, okay? The outer portion right here of the joint capsule is made of dense irregular connective tissue, and then it weaves into the periosteum of each bone, right? And creates basically a capsule around, right? And then the inner layer of the capsule is lined by the synovial membrane, and it's got fluid between them. So you can move it, and the cartilage actually doesn't rub against itself. If you lose the fluid, then the cartilage will start to degenerate, which is part of what happens with arthritis. Does that make sense? Okay, so a synovial joint Has the capsule filled with synovial fluid and hyaline cartilage. There are a bunch of different kinds of synovial joints. I don't hold you guys responsible for them just because you've got too much to do anyway. They have different levels of mobility. Here's a ball and socket joint. They're super duper wiggly. These guys right here, right there. There's also hinge joints like here that are really only move in one plane, right? There's a bunch of different kinds of joints. I will not test you on them. I will not test you on the categories of synovial joints. I will test you on synovial joints, but not the different categories. Okay, so as far as the structure goes, we did most of it. The structure of a synovial joint, you've got your articular cartilage, your joint cavity, your articular capsule that's got an outer layer of dense irregular connective tissue that's continuous with periosteum, an inner layer of synovial membrane that secretes the fluid, right? And then the fluid is really, interestingly, the fluid makes it so that the cartilages actually don't really touch one another. And have you guys ever hydroplaned in your car right after it rains, right? So you know if the viscosity of the oil on the ground is just right, it will actually support an entire car and you're actually not touching the ground. Well, if the viscosity of the synovial fluid is just right, then actually it's supporting your entire joint instead of smashing the two of them together. Does that make sense? So that's what that fluid does. It's a lubricant, it minimizes friction. In addition, it also nourishes the cartilages, right? So as long as it's healthy, your articular cartilage is not going to get damaged. Now, other stuff is in there that is not shown in this picture. So let me just show you this picture. Okay, so this is a knee. The knee is a bit problematic, in part because remember, we are a bipedal organism that evolved from quadrupeds, right? And think about how much stress goes on my knees when I'm a bipedal organism compared to a quadruped, right? You increase the amount of stress probably by double, right? You probably double the amount of stress, and then get fat. And then think about what happens with your knees, right? Okay. And then also remember that the knees are pretty much evolved to move in this plane. But if you're standing like this and then their primary source, you can get hit from the side and you can actually damage them. They are not adapted to move from that side. So what you have going through the joint cavities that help to stabilize your synovial joints is different ligaments, right? And you guys have probably heard of ACL tears, MCL tears. A lot of times will happen with athletes, football players and soccer players like to get hit from the side, right? And do those things heal really well? They do not heal very well. Ligaments and tendons don't have very good blood supply. So we've got some ligaments that are going through them. In addition, what else helps to stabilize these joints, whether it's the knee or any other, is that you'll also have muscles, right, that strap across, right? So if this is my rectus femoris muscle, it's going to strap across down here. The stronger this muscle is, the more it stabilizes the joint. That makes sense? So if the muscle is nice and strong, now the ligaments are inside the joint cavity, but the muscle is outside the joint cavity, but it helps to stabilize the joint, right? So if you want to stabilize the joint like you got a really bad back, do they tell you to just not use your back? No, they tell you to strengthen your abs and your back to stabilize the joint, right? As long as you can do it without doing further damage. So you have reinforcing, you've got ligaments, you've got tendons that are attached to muscles. In addition, if you are the knee, I don't know why they didn't draw it. Oh, they do have it there. In addition to the articular cartilage, did you guys get to see the lateral and medial meniscus when you did the cowbone dissection? If you didn't do the cowbone dissection last week, will you ask to do it this week because you've got more time this week? But we still have the bones. So in addition to the typical articular cartilage that you've got in every synovial joint, you have two pads, extra pads of fibrocartilage called the lateral and medial meniscus that seemed to develop with bipedalism. Yeah? We can see them get thicker as primates get more and more bipedal. We can see them be thicker in bonobos than they are in chimpanzees. Bonobos are more bipedal. We can see them be very, very thick in humans. So you've got 2 extra pads on the side of fibrocartilage called the lateral and medial meniscus, and they are in addition to everything else. Everybody good? Okay. All right, so just like your bones can start to go bad on you, your joints can as well. Okay, so let's talk about arthritis. Arthritis is actually a more general term than you think it is. It just means inflammation or degeneration of joints. It's not always associated with aging. There's several different kinds of arthritis. First off, there are 2 different big categories of arthritis, acute arthritis versus chronic arthritis. Do you guys know the difference between acute and chronic? You probably do.
Chronic is like kind of a forever thing.
Yeah, chronic lasts for a really long time. Acute usually has a predictable course. Just think about STDs, herpes. Chronic, right? Gonorrhea, acute. Yes, it's acute STD. It's not that cute. So, does that make sense to you guys? So there is actually acute arthritis that actually has a short course usually, and those are usually infectious arthritises. There are some pathogens that like to infect your joint cavities, believe it or not. Lyme disease is one of them. Lyme disease can infect your joint cavity. If you actually take care of it before it causes damage, then it's acute. Tuberculosis, TB, as if you didn't have enough problems if you got tuberculosis, it will also cause joint damage. Rheumatic fever, which is what I had that causes heart damage, it also causes joint damage. I didn't seem to get any joint damage from it, but rheumatic fever, those are all due to usually a pathogen invading the joint cavity. And if you get rid of the pathogen before you've done permanent damage, then you'll get over it, right? But what about chronic arthritis? Chronic arthritis, there are several different kinds. The kind that we usually mean when we just say arthritis is osteoarthritis. Osteoarthritis is wear and tear arthritis. We often associate it with aging, but it's also associated with repetitive use and injury. So I know that you think of grandpa getting arthritis, yeah? But now I want you to think about a professional baseball pitcher. Where are they going to get arthritis? They're going to get it in their shoulder. And if you're a tennis player, where are you going to get it? In your elbow. And if you're a slalom skier, where are you going to get it? In your knees. It is repetitive use arthritis. It is wear and tear arthritis. It increases in likelihood as you age, but with repetitive use or injury, you will get it in any joint potentially. So this is osteoarthritis. You can see what's happening. So let me tell you what's going on inside the joints with osteoarthritis. So degeneration of articular cartilage occurs as you age and you don't have as much synovial fluid, or as you wear out the joint and the synovial fluid production can't keep up with the activity level. In addition, as you age, your circulation gets poorer, right? So you're not bringing as much fluid to the area. And there's a genetic predisposition. So if you have a genetic predisposition, that means you have less cartilage in your articular cartilages, less collagen in your articular cartilages. Does it make sense to you that you would have a predisposition to arthritis? Yeah? So if there's less collagen there, you're just going to have a predisposition. So the exposed bone, if you wear down the cartilages, then the exposed bone will press against bone. And you'll start to increase bone mass and decrease mobility at the joint. Form bone spurs which restrict movement. Who gets osteoarthritis? Anybody? Independent of sex. As you age, you are more likely to get it, especially in joints that have repetitive use. Weight-bearing joints, hips, knees, distal phalanges. Women are more likely to get it in their hips because of the angle of our hips compared to men. So both sexes in their knees and your distal phalanges, it's hard not to use them repetitively, so you're more likely to get osteoarthritis there. What do you do about it? Pretty much just treat the inflammatory, treat the inflammation, treat the pain involved. There's not really much cure. If you damage a joint, you're far more likely to get arthritis in the joint than if you didn't. So usually some kind of aspirin or non-steroidal anti-inflammatory, or if it gets really painful, you can do a prescription COX-2 inhibitor, those kinds of things. But there really isn't a cure for osteoarthritis. Especially since even if you did it surgically, look at how many freaking joints you have in a single hand, right? I broke my finger, see my finger? I broke it 2 years ago helping my husband with speakers, and I've got osteoarthritis in that one, and it ain't moving. They go past there, it doesn't straighten anymore. So if you damage a joint, you're more likely to get insurance. Okay, we will stop there and we'll do the other arthritises next time.